Welcome to this component of the Intensive Review of Internal Medicine 2020. My name is Paul Ridker. I have the honor of serving as the Eugene Brownwald Professor of Medicine at the Harvard Medical School. I'm a cardiologist at the Brigham, and I'll be talking about inflammation and atherothrombosis, what clinicians need to know. I have a variety of conflicts of interest shown in this slide, which reflect the fact that this has been the fundamental issue for my research group over the past 30 to 35 years. I'm going to give this talk from a very clinical perspective because I think we're at a time when inflammation and atherosclerosis has finally come full circle. Traditionally, we've introduced this topic with this slide. Can targeted anti-cytokine therapy reduce cardiovascular event rates and prolong life? The patient on the right obviously has quite severe rheumatoid arthritis. This is a disease that even our medical students understand at some level is a dysfunction of innate immune processes. On the left is a patient with severe systemic atherosclerosis. You see the descending aorta and the bifurcation. And the real argument being made by the vascular biology community over the last 25 years is that these disorders share a tremendous commonality. And what we don't yet understand is why inflammation affects in one patient the joints and another patient the vascular endothelium. But we now have clinical evidence that just like we can treat rheumatoid arthritis, we can actually treat and postpone atherosclerosis with anti-inflammatory medications. The other end of this is a concept, a clinical concept that we call residual inflammatory risk. This is an editorial we published a few years ago about the obverse or the backside of the atherosclerosis prevention coin. The general idea here is that my clinic, a pretty standard clinic, is filled with patients who have both hyperlipidemia and elevated levels of high sensitivity C-reactive protein or hsCRP. So most patients with atherosclerosis are both hyperlipidemic and pro-inflammatory. Most aggressive sites will give high intensity statins to these patients. For years, we've talked about the patient on the left, residual cholesterol risk. What do we do when, despite being on a statin, the cholesterol is not low enough? In this example, it's still above 100 milligrams per deciliter. And I would argue there's plenty of clinical trials and evidence that we can take the LDL lower, and that's good for our patients. What's new, and the reason this update is important, is what's on the right-hand side of the slide, a demonstration that there are patients with residual inflammatory risk. These are patients who, despite being on a high intensity statin, the LDL in this case is quite low, down to 70, but the CRP is still very elevated. And the question becomes, what do we do with these patients? And do we have comparable data to say their risk can be lowered? Well, in 2020, the answer is yes, we have that data. On the left, I show you one of the many PCSK9 trials that shows that if you take the LDL very low, yes, you get further benefits, about a 15% risk reduction. This is a therapy that gives you profound LDL lowering, but no anti-inflammatory effects. On the right-hand side, the data I'll come back to in a few minutes come from our CANTOS trial. This is a trial of pure interleukin-1 beta inhibition. That is an innate pathway inhibitor of innate immunity. The critical thing is there's no change in LDL cholesterol and the exact same 15% risk reduction. But what I want to tell today is a bit of a story about how we got there and why this is going to be clinically so important. So, if you're interested in a little bit of the history, in 1999 on the left, Russell Ross, and in 2005, Garan Hansen published review articles in New England Journal of Medicine talking about atherosclerosis as an inflammatory disease. And these were early pathophysiologic papers talking about the biology relevant to this field. Our group, however, took a very clinical approach to this. So, this is a paper that we published some 23 years ago. First paper showing that if a patient has an elevated level of C-reactive protein, that is a pro-inflammatory response, that this measure of low-grade systemic inflammation precedes by many years the onset of acute vascular events. The reason this paper was important was because at the time, there was controversy about whether inflammation in the vessels was a response to underlying ischemia. This paper said no. The inflammation is there years in advance of an acute ischemic event. It makes it very much like LDL cholesterol, like blood pressure. It's a risk factor for the future development of disease. And we got very lucky. This happened to be done in the context of a randomized trial of aspirin, an anti-inflammatory drug. And we were able to show that the benefit of being on aspirin was greater in the presence of inflammation than its absence. And this begins this entire exploration that would eventually lead to the clinical trial showing that if we lower inflammation, we can lower vascular risk. I want to be very clear up front. The high sensitivity CRP is a very useful clinical test. It's the only approved test for this purpose. It's the test that's been endorsed by the AHA and the ACC and guidelines worldwide to be used for inflammatory risk prediction. But it's a biomarker of a downstream process where the upstream issue is interleukin 1 and interleukin 6. These are the signaling cytokines that drive the production of CRP. And this is data, again, from our group from 20 years ago showing that IL-6 levels measured in healthy individuals predict future vascular events. This assay, however, is not available for clinical practice for a variety of reasons. But the idea really is we want to inhibit this IL-1 to IL-6 axis. The CRP itself is the resultant downstream biomarker. Now, in the early literature in this field, and we published a series of New England Journal papers here between 2000 and 2002, we began to notice that a variety of pro-inflammatory molecules all predicted future vascular risk. What you see, though, in the color diagrams on the right is increasing quintiles of LDL cholesterol, on the left, increasing quintiles of CRP, and they're both powerful predictors of future vascular risk. But the critical insight in this field was that these are not related to each other. That's one of the most important things we can do today from a teaching perspective. You cannot tell your patient's or your own inflammatory profile from the lipid profile. They're not related to each other, but they both predict vascular events. And so if we're going to understand why a patient is at particular risk, and I would argue if we're going to logically understand why we would use one drug instead of another to treat that risk, we have to understand the underlying biology. Now, in 1999, this test was released for commercial use, and this was our publication at the time describing the first high throughput, high sensitivity CRP assay. My colleague, Nader Rafai, who's at Children's Hospital, helped to develop this test along with Russell Tracy, another talented clinical chemist at the University of Vermont. The lower right-hand side of the slide's most important issue here is that you see here how increasing levels of high sensitivity CRP, less than 1 to 3, and greater than 3 milligrams per deciliter, continue to this day to predict lower, moderate, and higher cardiovascular risk. What I want to emphasize, however, is that beyond risk prediction, we now know that lowering CRP, just like lowering LDL, actually lowers vascular event rates, at least with some proven therapies. And the questions are which ones and how can we use them in practice? Now, one of the critical issues clinically is to recognize that the magnitude of independent risk associated with this inflammatory response on a population basis is at least as large, if not larger, than that of blood pressure and cholesterol. These data come from a meta-analysis, which itself is now over a decade old, showing that each standard deviation increase in C-reactive protein is associated with a risk of a future vascular event at least as large as that of blood pressure and cholesterol. But of course, we at the time had done many, many blood pressure lowering trials and many lipid lowering trials, but not very many studies actually none had been done, demonstrating that lowering inflammation could lower vascular risk. And then finally, in terms of introductory comments, this is again is 20-year-old data where we worked with the cholesterol and recurrent events investigators, one of the big statin trials early on, to show that statins, drugs that we think of as the bedrock LDL lowering drugs in therapy, we're able to show on the right these drugs also lower CRP. So these are lipid lowering, LDL lowering anti-inflammatory drugs. They have two different effects. And on the left-hand side, that the magnitude of clinical benefit of being on these drugs was substantially greater in the presence of inflammation than its absence. So this was important because it suggested that one of the reasons these drugs are perhaps so effective is they not only lower LDL cholesterol very effectively, but they also have clinically relevant anti-inflammatory effects. And over the years, we would show a series of studies that when you lowered both the CRP and the LDL cholesterol, you got greater benefits. I show this slide just to emphasize that from a clinician's perspective, you can't tell what the on-treatment LDL level, which is what our guidelines tell us to measure, does not predict the on-treatment CRP level. It's a scatter plot. So you have to think about these two different biologies, and the only way to know what your patient's actually doing is to measure both of these parameters and figure out, is this a residual inflammatory risk patient or is this a residual cholesterol risk patient? Now, in 2005 on the left, and exactly a decade later, my colleague Aaron Bahula on the right, well, these papers were survival curves showing that when you got aggressive lipid lowering, the best outcomes were clearly among those individuals who both lowered the LDL cholesterol and lowered the CRP. This is the data in the red line at the bottom. This was better than just getting the CRP down, just getting the LDL down, or neither. And again, we've argued for many years that this is probably a great insight into why lipid-lowering drugs are effective and why we as clinicians need to pay attention to the inflammatory hypothesis as well as the lipid hypothesis. And then finally, in 2008, we published the results of the large-scale Jupiter trial. This was nearly 18,000 patients worldwide, primary prevention, none of whom would have received a statin under any guideline at the time because the LDL cholesterols were too high. Everybody in this trial had an LDL that was already well below treatment targets, but they all had an elevated CRP. We gave them a powerful statin at 20 milligrams of rosuvastatin, and we got a 44% reduction in vascular event rates. Now, those of you who are well aware of the statin literature know that this is the largest risk reduction shown in any statin trial. And I've always felt that's because this was the only trial that really leveraged the two different benefits of the drug, the LDL lowering benefits, and because we targeted this pro-inflammatory residual inflammatory risk patient, we augmented the inflammatory benefits, and that's always been my view of why we got such a large reduction in vascular event rates. And at the bottom of the slide, you see we had a 48% reduction in first ever stroke. So, of course, on the basis of this and other data, the guidelines worldwide would change to be much more aggressive with statin therapy. And as you well know, our current ACC/AHA guidelines have lowered the thresholds of who should get a statin enormously, and that's been a very good outcome of this entire passage of research. Interestingly, I want you to think about this, we also lowered the risk of getting a deep vein thrombosis or a pulmonary emboli by about 43%. This is important because inflammation is a very fundamental driver of thrombosis, but LDL cholesterol really is not. And of course, there's no plaque to rupture in the veins. So this kind of observation was very helpful to understand how these drugs are actually working. Now, to get to the more recent studies, we have to ask ourselves, well, how do we ultimately test the inflammatory hypothesis of atherosclerosis? The Jupiter trial was a lipid lowering study. I mean, we lowered the LDL cholesterol levels, and yes, we had some additional CRP lowering, but at the end of the day, we need to figure out a way to only lower inflammation to actually test this hypothesis without any confounding effects on blood pressure or lipids or hemoglobin A1C or thrombosis. So one way of doing this would have been to lower CRP itself. On the left, you see the cover of Nature from many years ago, Aiming for the Heart. We thought that lowering CRP per se was not the goal. The goal was to lower this IL-1 to IL-6 axis. CRP reduction would be a concomitant outcome of doing so, and that's really the direction that we took. So let me slow down a little bit and describe to you some relatively novel biologic concepts that are very important for understanding how this whole issue is playing out and what the future therapies are going to be. As we move upstream from CRP, our biomarker at the bottom, to interleukin 6 and interleukin 1 beta, which are important signaling cytokines that activate these processes. These are generated through the so-called NLRP3 inflammasome, which is a set of intracellular proteins inside certain cells that react to exogenous stimuli, some of which are noted at the top here: cholesterol, crystals, netosis, atheroprone, flow, and hypoxia. The really crucial issue is that this inflammasome is present in all of us, and is a very important activation for pro-interleukin 1 beta through an enzyme called caspase 1. Active IL-1 beta is secreted, and this cascade starts. And the insight that we had was that we could actually inhibit this cascade, and could we figure out a way to test this core hypothesis? And I'm going to take you through two different interventions that have been successful in this arena. So the first is a drug called canakinumab. So in about 2009, early 2010, Peter Libby and I went to Basel, Switzerland, and talked to the folks at Novartis. They have this drug. You see the drug in the lower left. This is a monoclonal antibody that targets interleukin 1 beta very specifically, and it slows down this inflammasome activation process. So in the black and white slide at the upper left, you see a scan electron micrograph of a cholesterol crystal piercing a vascular endothelium. You see the innate immune cell nestled up against it. On the right-hand side, the cover of Science, you see again the cholesterol crystal inside this netosis-prone plaque. This is the idea that we would try to inhibit this process by lowering the IL-1 beta itself. And we had to show that this might be effective, and it also did not have any confounding in terms of other issues. So to summarize a lot of work very quickly, we organized a 10,000 patient multinational clinical trial that was conducted in some 39 countries between 2011 and 2017. It's a very large study, had almost 1,500 primary events. This is a secondary prevention study. So unlike the Jupiter trial, which was primary prevention, these are those residual inflammatory risk patients. They've already had a prior vascular event, a myocardial infarction. They're already on aggressive therapy, but the CRP is still greater than 2. So they, by definition, have residual inflammatory risk. For some complicated reasons, we randomized the patients to one of 3 doses of this interleukin-1 beta inhibitor known as canakinumab versus placebo. And this was a hard endpoint trial. The first piece of evidence was that we lowered CRP. We did that by lowering IL-1 and IL-6. As you can see at the top, that was done in a dose-dependent manner. But very important for the hypothesis, no change in LDL, no change in HDL, no change in triglycerides. So this is a pure IL-1 non-lipid-based intervention. And in other data we've published since, no change in blood pressure and no change in hemoglobin A1C. And we got the same 15 to 17% reduction in major adverse cardiovascular events on the left, or major adverse cardiovascular events plus revascularization procedures on the right. Exactly the same benefits seen in the very large PCSK9 trials, but now in the absence of any LDL lowering. So this is important because what CANTOS provides is proof of principle that lowering inflammation, at least through this very narrowly targeted interleukin-1 to IL-6 pathway, clearly lowers vascular events as much as lipid lowering, but does so without changing cholesterol at all. We were unable to find any subgroup of patients who, assuming they had residual inflammatory risk, didn't benefit. Equally effective in men and women, older, younger, diabetic, and non-diabetic. Remember, everybody in this trial, however, had an elevated CRP. What we did find, however, was that those people who got the greatest reduction in inflammation got the greatest clinical benefit. Another important concept. The same way we say, well, if you get the LDL to go down more, you get a greater benefit, or the blood pressure comes down more aggressively, we get greater benefit. That's exactly what we saw here. What you see on the left is the on-treatment CRP levels, and on the right, the on-treatment IL-6 levels. This drug was only dosed once every 4 months, and so we would measure the on-treatment level of either CRP or IL-6 after that very first dose. And then we define people as responders, robust responders, or less robust responders. And as you can tell here, we'll just focus on the IL-6 data on the right. Nearly a 36% reduction in vascular events if the patient responded aggressively to this drug. The others less so. And I think this is all the concepts underlying personalized medicine. We want to get the right drug to the right patient at the right time. Now, as those who know this data are aware, we don't have access to canakinumab for our cardiovascular patients, not because it didn't work and not because it wasn't safe, but simply because we had another fundamental finding in this trial, which is that we had a very large reduction in incident lung cancer. So again, I show you here the placebo at the top, low dose, middle dose, and high dose canakinumab, and you see this 67% reduction in ever developing lung cancer. This would change the priorities of the drug for the sponsor, Novartis, who are aggressively pursuing this drug now for oncology purposes. And part of the reason is shown here, because these are the fatal lung cancer data. And as you see at the bottom, there wasn't a single fatal event in the first 2 years of the highest dose of the drug. So what's happening right now is that this drug is getting repurposed into the oncology arena, which has left a bit of a gap for the cardiovascular community. But nonetheless, proof of principle that lowering inflammation works both for lung cancer and for atherosclerosis. And that is important for us to understand from a biomedical perspective. Now, while we were doing our CANTOS trial, which is summarized at the top, my research group was also running the cardiovascular inflammation reduction trial, which was funded by the National Heart, Lung, and Blood Institute. I'm going to summarize it very briefly because that study did not work. We gave their low-dose methotrexate, the same drug used to treat rheumatoid arthritis very commonly. But what we discovered was in this atherosclerosis population, it neither lowered interleukin-1 beta, it did not lower IL-6, it did not lower CRP. So perhaps it's not surprising at all that it also did not lower cardiovascular events. So where are we and where are we going? This is a slide I'm going to repeat again later in my talk. Again, it looks familiar. You see in the center the NLRP3 inflammasome putting out both interleukin-1 beta and interleukin-18. both of which augment the downstream production of interleukin 6, which at the level of the liver puts out our biomarker, the thermometer of inflammatory risk, the C reactive protein. I've taken you through the IL-1 beta inhibitor data, but I want you to be aware of the fact that there are many other drugs out there that inhibit interleukin 6, that inhibit interleukin 18, that are direct NLRP3 inhibitors. And there's an interesting drug, colchicine, which is not a direct inhibitor of this process. It's a microtubular polymerization inhibitor. Colchicine is a drug that sometimes we as internists might use as a second line drug for arthritis. Sometimes I've given it for pericarditis in short term periods of time. Difficult drug for our patients to tolerate because of GI symptoms, but it does disrupt the construction of this inflammasome. And colleagues of ours at the University of Montreal Heart published last year, at the end of last year, data from a very interesting clinical trial called COLCOT. Nearly 5,000 patients who, again, like our patients, were very aggressively treated. But the drug they got was this colchicine. And what the trial showed was a statistically significant reduction in cardiovascular events, again, by lowering that central IL-1 to IL-6 to CRP pathway, something that, again, now we have two clinical trials showing that this is very effective in the absence of any evidence of cholesterol lowering. Now, the results of COLCOT are shown here. The hazard ratio is 0.77, a significant p-value of 0.02. More traditional cardiovascular endpoint you see here was not achieved. But the point here is that the point estimates are all in the right direction. So I see this as very exciting. And there's other colchicine trials up and running. And if they also turn out to be positive, and we should hear that by the end of the year, then I think we'll have a real opportunity to change our guidelines and maybe move forward with an inexpensive therapy for atherosclerosis. So I want to come back to where we started, this idea of residual inflammatory risk, the patient on the right being very different than the patient on the left. And I think from a biologic perspective, we want to think about who are these patients and can we get the right drug to the right patient? With my clinical colleagues, I sometimes say, look, you're not measuring CRP. We don't know which one of the patients you're treating. But I want to point out, and this surprises many people, there's 3 times as many patients on the right who have residual inflammatory risk than patients on the left who have residual cholesterol risk. But I don't want you to take my word for that. This is the data for that. 3 different major contemporary clinical trials, Prove It, Improve It, and the SPIRE-1, SPIRE-2 PCSK9 trials. Residual inflammatory risk is in blue. That's about a third of all the patients. Residual cholesterol risk is only 12, 13% of the patients. And so I think that this is the kind of thing we have to think about clinically. And I would argue if you're not measuring LDL, you can't tell who has hyperlipidemia. If you're not measuring CRP, it's very difficult to figure out who's got this inflammatory problem. And finally, even if we were to give everybody a combination of a PCSK9 inhibitor, as you've heard from other speakers in this IRAM course, yes, we could get the LDL very low, but we would not have altered this inflammatory response. This is data on the left from Fourier, which was one of the big PCSK9 trials. On the right, the data from another one, just showing that the on-treatment CRP levels still very powerful predictor of residual risk. So the idea here is, in the future, will we be inhibiting both of these processes, both the inflammation and the hyperlipidemia? Now, we just presented some new data that were a little bit worrisome to us, asking the question, how much progress, if any, have we made in 30 years on this hypothesis? And the answer is not very much. These are data on the left for IL-6 and LDL cholesterol, on the right for CRP and LDL cholesterol, just demonstrating that despite all this elegant biology, we are in a situation now where these two things add to each other, and we haven't really made that much impact on the outcome. A couple of things for to think about. Diet, exercise, smoking cessation really matter. This is the data for diet. Diets that are increased in omega-3 fatty acids and fish, that are reduced saturated and trans fats, good diets, fruits, vegetables, and nuts, all do lower inflammation, and of course, they all benefit our patients. I would argue that smoking cessation is a very good anti-inflammatory intervention. And we know that exercise also helps enormously for this process. So these also underlie the sort of core basics of a preventive cardiology structure. This is data from the PREDIMED study that many of you are aware of, where people were simply randomized in Spain, an underlying Mediterranean diet, to get nuts and or extra virgin olive oil, and as you're well aware, reduction in vascular event rates. I love the quote at the top: "The Western diet appears to be mistakenly recognized by the immune system as a threat to the organism." This is what this whole anti-inflammatory diet issue is all about. Now, before I end, I just want to update you a little bit on COVID. It's very difficult in this time not to do that. This is the same slide I showed before, but we've been pulled into this whole COVID arena because the same activation system between interleukin 1, interleukin 6, and CRP is also extremely important for the so called cytokine storm that we've all been learning about in the setting of COVID 19. So it's no surprise to me at all that the exact same drugs that we've been talking about here, interleukin 6 inhibitors, interleukin 1 inhibitors, direct oral NLRP3 inhibitors, are also being experimentally used now in the setting of COVID because our patients who are getting severe cytokine activation syndrome and therefore ending up in our intensive care units. These are the same kinds of issues that are being used to block this process. And part of this is just for you to be aware of why those trials are being done. And also part of it is to underscore the systemic biology nature of this whole issue of innate immune function. And last, I want to point out to you that CRP levels, baseline CRP levels in healthy individuals, just last week were shown for the first time to actually predict the risk of developing COVID down the line. That doesn't surprise me. It suggests that people with a underlying activation of their innate immune system are in fact at high risk for future development of COVID. And so again, we're seeing some commonalities between what's happening here and what's happening in the atherosclerotic and I would argue cancer arenas. So let me bring this to a close with some summary discussions. First, atherosclerosis is a disorder driven by lipid accumulation and inflammation. This is now what we teach the Harvard medical students in the first year pathophysiologic courses. We no longer teach atherosclerosis as a lipid disease only. Number two, the high sensitivity CRP test is as strong a risk marker for heart disease as is LDL cholesterol or blood pressure. It has similar variability over time. Diet, exercise, and smoking cessation all lower CRP and all lower cardiovascular risk. I would argue that if you're not measuring it, it's very hard to know whether our patient needs inflammation inhibition or needs further LDL lowering. Number three, in primary prevention, the Jupiter trial published 10 years ago proved to us that patients with elevated CRP need to be on statin therapy, even if their lipid levels are low. That's without dispute, and that changed the guidelines. Number four, in secondary prevention, the CANTOS trial I talked about provides us with proof of principle that inflammation inhibition in the absence of lipid lowering can improve atherothrombotic outcomes. This is the first hard evidence in some 40 years of an effective therapy for atherosclerosis that's not directly related to cholesterol reduction, to blood pressure, or to coagulation. Number five, taken together the positive CANTOS data and the neutral data from the methotrexate trial tells us something very important. This central IL-1 beta to IL-6 to CRP pathway of innate immunity is crucial for atheroprotection. Number six, the new data from Colcott provides clinically important independent confirmation of this inflammatory hypothesis with an apparently safe and quite inexpensive agent, colchicine. The good news, again, several other trials are ongoing, including a 5,000 patient study called the DOCO-2, which may be available by the end of the year. And if that's also positive, I think we'll have affirmation of this and perhaps an inexpensive way of treating residual inflammatory risk. Number seven, importantly, quality cardiovascular care, to me, requires us to recognize a distinction between residual cholesterol risk and residual inflammatory risk. These patient groups have different reasons for recurrent vascular events. Number eight, future clinical trials in this arena are likely to focus on alternative IL-1 agents, on IL-6 directly, and perhaps on upstream NLRP3 inhibition itself. And finally, what I think is probably going to be the future of atherosclerosis, I think we can anticipate that all atherosclerosis patients down the road will probably receive some combination of aggressive lipid lowering and inflammation inhibiting therapy. With that, I'm going to bring this lecture to a close. I greatly appreciate your watching this in the online version of the Intensive Review of Internal Medicine, and hope that this has been helpful to understand where the inflammation hypothesis is today and where it's going tomorrow.